Okay, so welcome everybody, one and all, to our panel discussion today on global health leadership, global perspectives on equity. This webinar is sponsored today by the Department of Global Health at the Indiana University Richard M. Fairbanks School of Public Health, as well as our school's doctoral program in global health leadership, the DrPH program committee on justice, equity, diversity, and inclusion, or the JEDI committee, as well as the Indiana chapter of the Fulbright Association. So we welcome all of you today, and looking forward to some great presentations and wonderful discussion afterwards. Slide, please. So this presentation today is in recognition of National Public Health Week. We welcome you to this panel discussion, and we will be highlighting applications of equity principles in the field of global public health. My name is Sue Babich, and I'm pleased to be the moderator for today's session. I'm a professor and associate dean of global health and acting chair of the Department of Global Health at the Fairbanks School of Public Health. And I'm going to sort of tee off the conversation here, and then we will have some opening remarks from my friend and colleague, Dr. Leslie Bozeman, who is president of the Indiana chapter of the Fulbright Association, and she's also the director of curriculum internationalization in the Office of International Affairs here at IUPUI. Our esteemed panelists are the following three people. These are I'm just giving very brief introductions, and you'll be getting to meet each of them in more depth when they have a chance to present. So we are really pleased to have with us today Dr. Chastity Walker. She is the Senior Health Equity Advisor at the Centers for Disease Control and Prevention based in Atlanta. And she's also an adjunct faculty member at the Fairbanks School of Public Health. Also, we have Janelle Williams, who is a doctoral scholar in the doctoral program in global health leadership. Janelle is also director of programming for Global Health Action. And we have with us Nadia Ali, founder and chief executive officer of Idea Labs Consulting. So I'm showing here generally the breakdown of our agenda for today. And I just want to say a couple of words to sort of frame up our discussion today. And then my remarks will be followed by opening remarks from Leslie Bozeman, our three individual presentations by our panelists. And then we are allocating at least 10 minutes to discussion among our panelists. And I do have a grand question that I'll be asking the three of them to respond to. And we'll then be opening it up to questions from the audience. And then we'll wrap up and talk about next steps. And we'll be providing you all with contact information for our panelists so that you have a chance to connect with them individually after the presentation. I do also want to give a shout out to the leadership team from our JEDI committee, Jason Turi, the past president, and Erica Thomas and Keith Barnett, the co-presidents of the committee. Joy Usigby is going to be in the background, one of our doctoral scholars, helping us with managing the chat today. And we've got lots and lots of other people who have been great help in helping to organize the sessions today. So just by way of just a brief framing up of what we're doing here today, we all share the value and goal of health equity and creating globally the conditions that will ensure opportunities for health and well-being for all. But this doesn't happen without intention and global collaboration and cooperation. In fact, it takes leadership. And it is well documented that there has been for a long, long time an urgent need for leadership development among the public health workforce, and actually well beyond the public health workforce. So this, in fact, is a mission of our doctoral program in global health leadership here at Fairbanks. We as a program have the mission of preparing diverse professionals with the skills and the will to apply those skills to create change that will advance the goal of health equity and health and well-being for all. So it's in that spirit that we are coming together today to talk with three panelists who have unique perspectives and contributions to share on their experiences in applying principles that advance health equity. In ahead of those panel presentations, though, I would like to turn the floor over to Dr. Leslie Bozeman. Leslie, take it away.
Thank you very much, Sue. Good afternoon, everyone. It is good to be here with you. I've served in the role of Director of Curriculum Internationalization in the IUPUI Office of International Affairs for the past 6 years. And I've been president of the Indiana chapter of the Fulbright Association for just over 2 years. And in that time, it's been a pleasure to work with my colleague, Dr. Sue Babich, on a variety of issues. I've learned a great deal from her, and it is really wonderful to be here as a part of this particular event. On behalf of the Indiana chapter of the Fulbright Association, I'd like for you to know that we're so pleased to be here co-sponsoring this event with the Fairbanks School of Public Health. The Fulbright program is the flagship international educational exchange program sponsored by the US government. And it's designed to increase mutual understanding between the people of the United States and the people of other countries. Fulbright offers grants to study, teach, and conduct research for US citizens to go abroad and for non-US citizens to come to the United States. Fulbright Association chapters like the Indiana chapter offer a variety of opportunities for Fulbrighters and friends of international education to gather around issues we value, reinforce and build new relationships, and also to encourage others to cultivate mutual understanding by sharing their own academic and professional passions through a Fulbright program. And that's what we are really promoting here today, is your academic passions and professional passions around global health. When our chapter board member, Dr. Babich, let us know about this particular event, we recognize the topic as aligning with one of the goals of the Fulbright Association programming, the goal of promoting meaningful conversations that drive the mission of peace through understanding. And we also saw an alignment between the JEDI Committee and our own chapter's objectives, specifically around inclusion. Our board members are all passionate about helping people from diverse backgrounds see themselves as potential candidates for Fulbright, and we're communicating that message loudly and striving to illuminate a path for people who have never thought Fulbright was for them. Fulbrighters around the world are addressing issues of health disparities through research, teaching, and professional projects. And I encourage members of the JEDI Committee, the presenters, and the audience today to consider how you can enhance the impact of your work in public health through a Fulbright Award. There are opportunities for students and faculty that I'll share with you in the chat in just a little bit. Personally, the experiences that I had through Fulbright, learning about the educational systems, cultures, and people of Brazil and South Korea, as well as educators from across the US, have stayed with me, and they've had a significant impact on my approach, not just to my work, but also to how I engage with others, think, and act in this world, which I think has a lot to do with the work that you are all doing in global health. So I'm looking forward to learning from the presenters today and to finding ways to help share your work and to continue the conversation about global health equity. Thank you all very much.
All right. So should I go ahead and get started? Oh, sorry, I think you're muted.
Thank you, Nadia. Thank you again, Dr. Leslie Bozeman, and I'll turn it over to you, Nadia, next. Nadia, founder and CEO of Idea Labs. Thank you so much.
Thank you so much. If you could go to the next slide, please. Hi, everyone. I am so excited to be here with all of you today. Thank you so much for having me. So a Jedi-centered leadership issue that I've worked on with a number of healthcare organizations has been focused on reimagining recruitment and really thinking through a systems lens about this question. How can we build a healthcare workforce that reflects the communities that we serve? Both, at the frontline and leadership levels. And so just to start off, I wanted to pose a question to all of you. What words come to mind when you think about reimagining recruitment? And feel free to use the chat to drop in some of those reflections and words. So give about 30 seconds for that. Start to see what comes through. Thanks, Jason. Mentorship. What else? Non-traditional recruitment methods. Love that. Awesome. We'll keep those reflections coming. Scholarships. Yes. Fantastic. Thank you all. Skills. Diversity. Yes. Thank you. Thank you so much. So, yes, all of this. Oh my gosh, it's totally resonating with me. So when I think about reimagining recruitment, a few things come to mind, cultural responsiveness. So to expand on that a bit, having an awareness of one's own cultural identity and views about difference, and then the ability to learn and build on the varying cultural and community norms of patients and their families served. Having a workforce that's identity affirming, having language ability, and all of the different things that you all are mentioning in the chat as well. So if you could go to the next slide, please. Thank you. So some key strategies that we've used in the past are shifting to a skill-based hiring model, implementing new interviewing practices to reduce bias, and developing pathways to leadership. So with regards to skills-based hiring, it really shifts the focus from educational credentials to competencies and qualities in candidates. And for a long time, education has been used as a proxy for ability. And several factors have made it clear that skills-based assessment can be more effective, especially for many frontline healthcare jobs. And some of those factors include, many skills that people have for one job can be easily transferred to another. There are now more channels for informal and non-traditional education, including online-based learning. And also strong potential candidates can oftentimes be excluded from the pool because of degree requirements. And so in terms of implementing new interviewing practices to reduce bias, strategies like using an interview guide with standardized questions, grading candidates on a rubric instead of debriefing immediately in a group to avoid groupthink, and having multiple people interview candidates to gain different perspectives and make sure your interview panel is diverse. So, people holding different positions and also making an effort to have some gender or racial diversity as well. And then lastly, when thinking about developing pathways to leadership, as folks are hired, thinking about after you've onboarded them, how are you investing in them? Are they receiving opportunities to be cross-trained, or have they been connected to a mentor or a resource group or things of that nature? And then on the last slide, in terms of successes and challenges, successes are around skills-based hiring has led to larger candidate pools, higher retention, greater diversity. You know, I've seen more people of color apply, women, people with disabilities. And then also the other success that I've seen is just deeper community partnerships, you know, with either local schools or other community-based organizations to start to build that talent pipeline once we sort of opened that up. And then in terms of challenges, you know, getting alignment and buy-in to remove degree requirements for some positions has oftentimes been met with some resistance there. You know, just doing having a lot of those conversations around, you know, why not? And, you know, it's a culture shift for people. So just having conversations with people who are in positions of power and have the ability to change those pathways. And then also changing current structures around interviews and those types of systems, also around how we're evaluating candidates. And then when I say time constraints, you know, just people have so much going on, and you know, we're so busy in the day-to-day. So like time constraints around collaborating with HR to co-develop additional levels within a job, you know, to create opportunities for growth and leadership, to actually see those changes in how candidates are evaluated or interviewed and how other people are looped in to be a part of interview panels. So things like that. Time is a really big challenge. And I'll just close by saying, you know, we need to be reflective of the community that we're serving. We need to be inclusive in our workforce. And, you know, when people see employees, nurses, doctors, techs, you know, engineers, office staff, people who look like them and are from similar backgrounds, they feel more welcomed in organizations as patients. So thank you so much.
Thank you. Super, super interesting. And I'm already jotting down notes of the questions I want to ask you, Nadia. Fantastic. Dr. Chastity Walker, over to you.
Thank you, Sue. And it's nice to be here. Good morning, afternoon, or evening, depending on where you are. As Sue mentioned, I'm Chastity Walker. I have the privilege of supporting and teaching at IU. And I also have the honor of serving the public with the U.S. Centers for Disease Control and Prevention for over 20 years. So thank you for allowing me to be here. I'm going to talk to you a little bit today about CDC's Health Equity Framework. Next slide, please. And so just a little background, in order to understand what CORE is, I'd like to take a step back and share how CORE began. In April of last year, or just around this time, CDC Director Dr. Walensky declared racism as a serious public health threat. And as a result, she committed CDC to focusing on the structural racism, discrimination, stigma, and disenfranchisement that drive inequities. The systems of power, privilege, and oppression that drive health disparities among racial and ethnic groups, but also those same things that intersect in the disadvantage due to their class, gender identity, sexual orientation, and other identity markers. And from this charge, an initiative that would later be known as CORE would move beyond naming differences through markers such as race to really identifying and addressing changeable drivers such as housing, neighborhood conditions, and access to healthcare. Next slide, please. So as a result, a leadership team comprised of members across 3 of our offices, the Office of Science, Office of Minority Health and Health Equity, and the Office of the Associate Director for Policy, convened to establish the framing, content, and coordination of CORE. And I was fortunate to be a part of that leadership team in developing CDC's CORE framework, where we sought and are seeking to engage every part of the agency to incorporate health equity as a foundational element with the goal of integrating health equity science into all that we do. And so CORE seeks to implement transformative, permanent changes through its 4 pillars shown here: cultivate, optimize, reinforce, and enhance. Next slide, please. To do this, we started at the division level. As you all may be aware, CDC is a very large organization. So I'll say that this was a challenge, but we were up for the challenge. And so across our 64 divisions, we looked at developing goals to catalyze the agency's commitment to health equity and identify the most impactful transformational work that will leverage CDC's critical agency initiatives and longstanding scientific work to advance and safeguard health equity. From this work, you can see around 43% of the goals are intended to advance health equity science. 17% are intervention focused, where we look at our programmatic work. 27% roughly are a combination of science and interventions. And the remaining 13% are really cross-cutting goals that facilitate policy, guidance, partnerships, and system changes that support agency-wide standards and implementation around a wide range of program areas. Next slide, please. From the 159 goals collected across the agency, our group identified 7 common themes, also known as the core aims. Building on CDC's strengths, many focused on using our surveillance systems to better understand not just the markers of health disparities, but also the drivers of inequities. Goals were focused on building CDC's health equity data capacity and leveraging our skills in analytics, statistics, modeling, and predictive approaches. Almost all divisions prioritize building the evidence base for health equity science, and many goals were focused on developing health equity interventions that were scalable at the national level and global as well. Key partnerships were identified, including many outside of the traditional lanes of public health, like housing and urban development or working with the Department of Transportation. Some of the goals focused on enhancing coordination across federal agencies and state and local public health, and others focused on building a diverse and inclusive workforce and improving our internal DEI&A infrastructure. Next slide, please. So now that I've shared what CORE is, I'd like to take time to share how the CORE framework is really being integrated within CDC's programmatic and scientific activities. So here's sort of a big picture, an image that we hope illustrates the reach of CORE, how we envision integrating health equity into the foundation of our work. Where you can see there are 3 main efforts we'd like to achieve as we integrate health equity. We want to leverage our existing work. CORE builds off of a vast amount of health equity work that has already been taking place for many, many years across the agency, including in programs, agency work groups, across our centers. And while many of the efforts listed here are deeply engaged in health equity activities, they also extend beyond just CORE. We want to coordinate across the agency. Different entities throughout CDC help assure that the CORE team is coordinated internally with other agency players and key partners, both internally and externally. And again, at the end of the day, we really want this to be a transformative process where we facilitate transformation in the context of health equity. So CORE really serves as a catalyst for health equity innovation with the 159 goals of the Health Equity Science and Innovation Strategy to set the stage for health equity. And agency sprint teams help provide guidelines for these innovations along with external partners as well. Next slide. With all of the transformative potential stemming from the CORE framework, our leadership team established and led what we call 4 sprint teams that were given a relatively short period of time, maybe about 3 months in total for each team, to really look at some concrete, tangible deliverables that can be utilized as we implement our strategy and embed health equity or bake in health equity to CDC's work. We've established foundational definitions or health equity glossary. We've developed health equity science principles, which are intended to be the basis of our scientific and evidence-based work. We've implemented measures of accountability and strategies for monitoring the implementation and achievement of these goals. And looking at our health equity guidance for our notices of funding opportunities, what structures can we put in place for our funding to ensure that it is equitably distributed, that the communities that we're trying to reach are also part of the process in really receiving those funds to support the work that's occurring. Next slide, please. And so I'll end by saying the core health equity framework is challenging CDC to incorporate health equity as a foundational element across all of CDC's work. This really is a shift from simply listing the markers of health disparities, which has been done for many, many years, toward identifying and addressing the root causes of drivers of these inequities through a combination of strong science, interventions, evaluation, partnerships, policy communication, and workforce enhancement. CDC is really striving to advance health equity and fulfill its pledge to ensure that all people have an opportunity to live as healthy as possible. So thank you for having me, and I look forward to questions later in the presentation.
Thank you so much. This was really encouraging to hear. Thank you. And our next panelist will be Janelle Williams, one of our doctoral scholars at Fairbanks and the Director of Programs for Global Health Action. Over to you, Janelle.
Thank you so much, Sue. Can you hear me all right?
Yes.
Perfect. All right. Well, good afternoon, everyone. And to some, good evening. I know we've got some folks from Kenya. I can see them on there. So welcome. As my colleagues previously shared, there's such good work happening all over the world. And when we speak about JEDI or JEDI, there are lots of areas that we can really focus in. Eric, if you can actually go back to that very first slide. And so what we're trying to do is here is sort of discuss this journey to health and well-being and the critical nature of equity in leadership in equity, and then of course, equity in health and global health. And I'll sort of bring a different spin to it, probably make it a bit more personal to my story. And so once again, I want to just say that I appreciate the professors, leaders, all of those who have gone before me, and of course, those who are walking alongside me every day. Thank you. Regarding this particular topic, I wanted to use the word leadership and do a quick play on it, right? It says leadership, leadership, and then of course, lead her ship. And so I'm going to use the her because I am a woman and I will use that and run with it. And so I played on that for a minute because again, leadership starts with me. Leadership starts with you. And I wanted to focus a bit on that because who I am, what I am is what I bring to the table every day. Regardless of the table I sit at, I bring myself, whether I accept that, whether you accept that, whether it is acknowledged or not, I bring me with me everywhere, every day. Now, how I bring myself, what piece of me is covered up, showed, held back, restricted, or displayed is also up to me. And to some extent, my environment, the structures, the people, the processes that I interact with every day have a direct impact on what I show, on what I bring, and what I allow. I think we have an incredible opportunity today to really determine what that external environment can be for us as well as others. It can be welcoming, certainly, and that can lead to more integrous and effective engagements, whether it's with customers, populations regarding interventions, governments to work alongside, or I can be unwelcomed and marginalized. I can also, on the other hand, become a pawn in a larger enterprise for disingenuous engagement for a different bottom line than the health and well-being of the most vulnerable populations. I have a choice. You have a choice. We have a choice. And sometimes these choices can be painful, and sometimes they can be gainful, and sometimes it simply doesn't matter. There is a different, larger, bigger goal at hand. One of my favorite quotes is from Shirley Chisholm. If they don't give you a seat at the table, bring a folding chair. My granddad was her chief of staff. He was one of the critical strategists for Black politics in New York many, many years ago, Dr. Wesley McDonald Holder. So I get it honestly. But I want to say this, you define which tables you want to sit at and why, and how are you encouraging more seats at that table and at other tables? Why do I ask? Because it is important and it matters to all of us. Share your power and privilege, bring others along with you. So I'm also a member of the JEDI Committee, one of the founding members. I am very proud to be a part of Global Health Action and working alongside many, many community-based, faith-based, government agencies and organizations. We have an opportunity to do something truly tremendous. So I'm going to move very quickly. Can we go to the next slide? And then I'm definitely going to wrap this up. I put this quote there, read it, because it's something I think is very critical, and that answers a lot of the questions that we'll sort of begin to delve into. The more radical the person is, the more fully he or she enters into reality, so that knowing it better, he or she can transform it. This is not afraid to confront, to listen, to see the world unveiled. This person is not afraid to meet the people or to enter into a dialogue with them. This person does not consider himself or herself the proprietor of history or of all people, or the liberator of the oppressed, but he or she does commit himself or herself within history to fight at their side. And for me, that sums up all things to do with justice, equity, diversity, and inclusion. Paulo Freire of the Pedagogy of the Oppressed is an incredible Brazilian educator, and truly, I think one of the greats that many folks who've been in the community organizing world have really been led by, if I should say it that way. Go to the next slide. This is also what I think is at the core of health equity, of global health equity. And so when you look on the left side, you know, this kind of, for those of us here in public health, right, we're talking about the socio-ecological model, really looking at what level are you operating at, what intervention to aim at. And I think this is very critical for all of us when we begin to think about the strategies and the tactics we want to implement, why and where are we sitting, what seat are we sitting at. On the right side, it shows you a strategic plan photo. And this is related to the organization that I'm with. We as an organization at the organizational level began to move very, very distinctly at looking at our core. Who are we, what do we do, and why do we do it? And I'll say this, we listen, we connect, we empower. And those words are not just simply words on a page, those very deep meaning, because that's how we engage with any of our partners. And what I'll share is that it took quite a few years for us to get to, because we spent a lot of time listening to the communities that we engage. And so when you start thinking about strategies, again, this comes down to our strategies. One of our core values that we begin to overtly articulate was that we're fighting for racial and gender equity. We're also igniting transformational leadership. And we can talk a little bit more about some of these areas and some of these ideas, but we've gotten very, very close to beginning to inform policy around the world. We can go to the next slide, but also starting very, very locally. On the left of this page, you're going to see a couple of Part A, Part B, Part C, and Part D. What is that? That's UNICEF's listing of indicators, sort of categorical indicators for addressing community engagement. This was the very first time that UNICEF came up with minimum standards for organizations operating in the humanitarian setting on how they engage both with governments and with local communities. So I have the opportunity of sitting down and working with the working groups to help define this, because one of the challenges that's found in the global health arena is certainly the idea that we're here to help. And so we give money based on our priorities, our identification of what the problem is, and our solutions. But very few times is the time allowed for the true community engagement to actually listen to what communities are saying are their needs and allowing them to really self-direct what the next steps need to be. So this was one of the first areas that we began to work on, is to help develop some policies at a global level and also an interagency level. On the right hand, we're looking at universal health coverage and working with the UN high-level meeting to actually come up with what civil society organizations around the world would like to really advocate for in terms of funding, in terms of definition of needs, and in definition of strategies moving forward. And so what we're going to begin to see in the next few years is a real focus on countries, organizations, agencies, really using universal health coverage as a rallying call to, frankly, address health disparities globally. And so I want us to move to the next slide. There are a couple of key things that I wanted to share. One, successes and challenges with this. One, understanding the context. We have to understand the global environment and the actors and the players at that level. We have to then understand how that affects the local implementation, but also the local communities that are involved and all of the stages in between. We have to be able to listen, but we also have to be able to capture that. And that means data creatively. We have to be able to connect. We have to be able to build networks and support those networks. And that's something that we're doing as an organization. We also have to empower, which means educating on all levels. Educating for certainly public health science, but also educating about community norms, community expectations, and community resilience. It all takes time. And so one of the things that I'll say can be a great failure is expecting something overnight that took centuries to build. And so this work that we are talking about is powerful, is strong, is encouraging, is wonderful. But I think one of the biggest things that I'll leave us with is this. We have an opportunity to simply not only live for ourselves, recognizing that 1,000 fibers connect us with our fellow men and women. And among those fibers, as sympathetic threads, our actions run as causes, and they come back to us as effects. Herman Melville, have a great moment to absorb that. And with that, I am done. Thank you, Sue.
Oh boy, Janelle. Okay, some very exciting, very encouraging ideas have been presented here. We're going to stop the recording at this point and begin some discussion. And we encourage everybody